Session. Hello, everyone. Welcome back after our break. If you're with us live, it's great to have you here. My name is Dr. Bronwyn Lee. I'm your conference host, and it's my pleasure to welcome you to session 3 of our very special conference. In this session, we are focusing on supporting dads and the couple relationship. For your information, if you are looking for the handouts associated with these presentations, you'll find them in the portal, and look for the directory. You'll find Sarah's presentation slides under the banner of her organization, which is Keeping Mum Psychology, and you'll find the handout for Ellie's presentation under Becoming Us. All right, please allow me to introduce our first speaker. And if we'll move to the next slide, and I'll introduce Sarah Edwards. Sarah is a clinical and educational and developmental psychologist who works in her solo private practice, Keeping Mum Psychology. Sarah will share a little bit more about herself shortly. In this presentation, Sarah will be speaking to us about dads. Welcome, Sarah.
Thank you very much, Bron. Hopefully you can see me and hear me here. Beautiful. Before we get started, I'd really love to acknowledge the Turrbal and Yugara peoples as the original owners and custodians of the lands of Meanjin or Brisbane. I'm so incredibly fortunate to live, practice and present from these lands. I pay respects to elders past, present and emerging. Today I'll be talking about dad and working with autistic and ADHD dads, but I'd also just like to have a note about diversity before we get moving. I'd like to acknowledge diversity here, that this talk focuses on fathers and hasn't included non-birthing partners. Fathers and non-birthing partners have their own unique needs in the perinatal period, and as confirmed with same-sex non-birthing people, presenting them together is not preferred. So I want you to know that we've reflected on diversity here, and so for that reason we'll be talking about dads. So a little bit about me. So I've had a job change, much like Jilly. I used to be a medical scientist when I first left school, and I really love data and I love science. Now I'm a psychologist in private practice, and I wear a few hats, including doing some lecturing and some supervision as well. I did my master's in education and developmental psychology, so I was trained in systems and attachment-oriented approaches. So naturally, I love to look at systems and I love to look at big pictures where I can. I'm married and I'm a mother to a 14-year-old and a 12-year-old son. And at this exact time, 12 years ago, I was holding my 12-year-old, my little baby boy, who was actually the beginning of much of my own internal psychology experience. So it's quite serendipitous that I'm talking about neurodivergence here today. I love dragging my family on international or any holidays. I'm now on a holiday ban. My family are mostly homebodies, but we're all really regulated by water. We love to spend a lot of time together on Moreton Island, either boating or four-wheel driving or spending time with our toes in the sand. So that's a little bit about me to get started. So why this topic for me with a practice name such as Keeping Mum Psychology? Where did dads fit in? And I think this was really informed clinically that so many of my mothers with ADHD and or autism were more likely to have partners with ADHD and or autism. There's currently no definitive research around the prevalence of neurodivergent matches in relationships as far as I can see. Ellie might be able to tell us more in her next presentation. But I sort of hypothesize that the double empathy problem that has been shared so beautifully about in this conference so far might be a really good hypothesis. If you're likely to have easier communication with a neurodivergent partner, you are more likely to end up with them. I think Sarah shared a more recent reference for the double empathy study, so I should probably include that as well. I think including dads as part of my practice, like my systemic sort of training demonstrated, I couldn't not see it. I couldn't not see the dads that were coming into practice and were demonstrating some of the signs and symptoms that I was also noticing in their partners. I also, probably to my extroverted nature, I really love working with the whole family, and I really love meeting all of the characters in the story because it can often give us so much data about what's happening. Just wait for my slides to catch up, hopefully. Something that my patients sort of get sick of me saying is that the whole family has a baby. It's not just mum. So the whole family, we need to consider them and hold in mind. And I think this is a really important part of clinical practice for all of us in all disciplines. So today, what I'm going to talk about is contextualizing dads and talking about their own psychological development. I think, it's nice for us to sit and spend a little bit of time thinking about that. I'd also like to talk about ADHD in dads and autism in dads, and then think about how can we support these dads in practice going forward. So we know, much like motherhood, fatherhood is a developmental milestone. We've got some beautiful literature, particularly by Stern, around the motherhood constellation and the motherhood trilogy. But our understanding of a father's psychological development is still mostly sort of hypothesized or wondered about. There's a beautiful study by Berman and Long who really talks about the father's experience sort of being more external, and it's more about wanting to protect the dyad and defining themselves outside of the mother-infant dyad. So I think that's a really important point for us to hold in mind. I also love the way that fatherhood is also described as the anguish of fatherhood, a process characterized by confusion and melancholy unknowingness. I think if that's not a great descriptor for parenthood, I don't know what would be. So when also sort of looking through the research in terms of thinking about fathers, I think this quote sums up beautifully. It's from research, but also I see this clinically too. The infant is a mystery to the father until the father experiences his infant as actively responsive to him. At this point, the father appears to undergo a highly effective internal reconstitution, which binds him to his infant and which begins to enrich his representation of himself as a father. Through the mirroring gaze of an infant, the father is conceived. And I think this is important for us to hold in mind, given that a mother is having the physical sensations of conceiving, of gestating the baby, whereas for fatherhood, perhaps it's actually more when baby is visible to him. And again, just another quote, which I thought was really lovely, is a journey to fatherhood is exploring the need for them to tolerate change and loneliness as they support and protect the new mother-infant dyad. While infantile anxieties of abandonment may be aroused, the importance of the father's role in the newly established family is essential. And I think, again, this is something that comes up for me in fatherhood, particularly around feeling loneliness, but also the idea of tolerating change, which of course is something really important for us to hold in mind for our neurodivergent fathers. So I think it's really important for us to acknowledge that the father role is changing, and there's some beautiful, social media footage around dads attending Taylor Swift conferences and getting gemmed up and dressed up. And I think this is sort of marking a change in what fathers are doing in our society. I think, like I've written here, the cultural images of what makes a good father has really changed over time, and it's gone from being a moral teacher to a breadwinner, to a sex role model, to a nurturer, and now involved is really where we're sort of starting to include. And I also think that this is kind of the hallmark of my talk, and I hope this is something that you will take away with you today, is father's involvement is possible when there is sufficient motivation, skills, self-efficacy, and social support in conjunction with an absence of institutional barriers. So fathers can do well when they're supported, well supported. I think it's important for us to know how important is dad's mental health, and really wonderful research by Richard Fletcher and his team really evaluated how fathers do in the first year postpartum. We know that depression in fathers during the first year of a child's life can have an impact both on the father, but also the child's development. And I think importantly, this is above and beyond what a mother's mental health difficulties can have. I think also something else for us to hold in mind is that pre-existing factors increase the likelihood for a dad to have difficulties in the postnatal period, including a history of depression and anxiety. And I've sort of asterisked that little point there because I think, is this anxiety or depression, or potentially, is this a dad that has neurodivergence on the table before baby comes along? So we also know that data on dads is really scant. A lot of the literature is really mother-centric, but we know that dads are their own species, and we can sort of think about that humorously, but we can also know that actually they have their own unique needs. They experience mental health challenges differently. They find it hard to seek help, and they have different ways of coping. But also the way that they experience their difficulties is also really shaped by the gender and parenting norms in society. Something that was incredibly profound to me, Bronwyn and I attended the Fatherhood Symposium this year, and I don't think I really realised how dads felt about, their visibility as part of the perinatal services. And I think this study really demonstrated that fathers often really appreciate the care that their partners receive and their babies receive. Again, if we think about this outside sort of observation of making sure that mum and baby are okay. But really, there's a lack of father-inclusive support, poor communication by health professionals. They often feel ignored and sidelined in maternity settings where they continue to be treated as visitors. And I think that the same results have been reported for the last 30 to 40 years, yet progress remains really slow. I also sort of want to acknowledge that society has also changed. It wasn't that long ago that fathers weren't allowed in maternity wards or birth suites. So we've had to sort of, things have really moved rapidly. But when I sort of read this quote that was shared at the symposium, I think, oh my gosh, we need to work a little bit harder to support families. This is a dad's quote. It said, "It would be too easy to say that I feel invisible. Instead, I feel painfully visible and entirely ignored." So when we think about our dads that are accessing our services, they might be having their own struggles that are not being made clear. So just to sort of start on ADHD dads, I think despite a heritability index of 0.88, which is remarkably high, there's barely any data following children with ADHD through to adulthood. I think we spend so much of our energy and time researching what causes ADHD when the answer has always been in the room. It's a neurodevelopmental diagnosis. It is lifelong. And I think, like Jilly sort of outlined this morning, that often I don't think a lot of psychoeducation is provided in childhood and how this might continue to impact the individual over their life. I think the symptoms change over the course of their life. And I think also there's a misunderstanding that it might go away. I think there's also a really beautiful description in Matilda Bosley's book around The Year I Met My Brain, where she really talks about the socialization of ADHD executive functioning and how for women it might become more exacerbated, or in men often it can be countered by having a really capable partner, or having a really capable woman that's able to sort of step in and make up for a lot of those differences. I also wonder, and this is probably more prevalent in my clinical practice, is that like women, I think there might also be a lack of diagnosis for high masking and or high IQ dads, or dads that are working really hard to look like they've got it all under control. So what does research say about ADHD dads? Like I just mentioned, there is nothing that has followed a child or a boy with ADHD through to adulthood to see the impact of that on his parenting. And I think there's also no sort of studies looking at the bidirectional impacts of having ADHD, so being parented by an ADHDer. Probably the only thing that we can say from research is that fathers with ADHD do have positive parenting. However, they have lower supportive responses to their child's negative emotions than comparison fathers. And I think that's a really important thing to think about, particularly given what has already been spoken so far about the conference, is that we sort of have to assume that people with ADHD or autistic neurotypes have already sort of experienced interpersonal difficulties or trauma related to their way of being in the world. So dads, who might have been little boys once upon a time that were unable to concentrate or do things well, may have sort of been responded to in a harsh way. So then when they have their own children, potentially for those familiar with Circle of Security, it might activate their shark music and they have low tolerance for their children's difficulties. That's my hypothesis, working hypothesis anyway. I think there's also a really beautiful study that's notices, and you'll also notice it's by the same researcher. She's championing research in ADHD. Parents with ADHD and their partners experience greater parenting distress in the first year of their child's life than parents without ADHD. And I think this is also certainly true in my clinical work. So what does research say about autistic dads? And I've got this drum roll image here to really demonstrate how exciting this will be, because there's absolutely nothing in research about dads with autism, yet we know that they exist. So in the lack of being able to find empirical research, I had a bit of a look online to see what anecdotes there were, or what could we draw on to sort of understand the experiences of autistic fathers. I think some of them are still quite deficit based and not really looking at the strengths, but that's probably all we have at this point in time. So a really brief summary of the anecdotes to save you having to have a bit of a look around. I think, autistic dads assume that they will struggle. They not know what to expect. They sort of have fear, anxiety about being a parent. Will I get overwhelmed? Which I think is a really reasonable assumption, and it's likely that they will. Trepidation around social interactions with health providers, which again, I think is really reasonable, and research is showing us that they're probably not going to have a good time with healthcare professionals, which it pains my heart to think about. But then also there's some strengths that came out of these anecdotal reports, which spoke about dads that are able to be highly organised, detail-oriented, and really good at providing structured routines and predictability. And of course, this is when they would have capacity to do so. So when I think about how there is such a lack of research in this area, I think, at this current state of play, ADHD and autism, there is a higher prevalence in males. And so, they're more likely to become dads. How is it true that we don't understand anything about their experiences? There's estimated at this stage to be about 300,000 autistic Australians and about 800,000 ADHDers. I'm probably preaching to the choir when I talk about the differences in diagnostics that are occurring right now, but I just think it's really not good enough for our dads that are having to become parents and are wanting to be parents and wanting to be really good parents. So I think it's a shame we don't know what ADHD and autistic dads struggle with, nor do we know their strengths. So much like the format that's already sort of been demonstrated during the conference, I've sort of outlined what we might notice in our clinical rooms if we include dads in our practice. Where are you, slide? So thankfully you'll have these slides, and I think that, hopefully they will be helpful for you. But I think holding in mind that they sort of feel ignored and dismissed as part of a perinatal setting already, but then also potentially having their own ideas around what social communication looks like. They may not feel they're allowed to be part of the conversation. They might not feel they have the rights and skills to advocate. I think this is also a really common fatherhood experience. They may also feel that if they have access any supports themselves, that it might take away from the mother and the baby as well. They may not communicate in neurotypical ways and be judged or scrutinised for this. I've got an example where a father was told one thing in a NICU by a nurse and then, turned up the following day and did the same thing that was, sort of suggested the day before. And another nurse sort of told him, no, that's not what we do. But in his way, trying to understand it and make sense of it, he sort of asked more questions and he was considered to be aggressive, or, communicate in a poor way. And so he was asked to be excluded from the NICU for the rest of the day. And so I just think, if we sort of understand that this is about understanding and really wanting to communicate why there might be two different ways of, being or responding in a NICU, then perhaps we can support our fathers a little bit better. They may not present typical non-verbal skills. Dads in birthing rooms might need time to themselves, and it might appear that they are not interested or uninvolved. And I think, we are also sort of always looking for clues that dads are interested and involved. And I think if they don't demonstrate that in a neurotypical way, they could sort of be dismissed and then treated poorly. Again, I've got many examples of this. Like our mothers, they may need longer to process information or have information documented or be able to take notes. I think they also need to feel safe with their care providers to communicate. Again, this has already been spoken about, but they may have literal understandings. And I think probably this example will stay with me for the rest of my life. Mark Williams, who is a beautiful fatherhood advocate in the UK, shared that he does a lot of work with birth trauma. And he had an autistic dad who was present during the birth, and mum had to be wheeled away to go to surgery. And a nurse very kindly, very well intentioned said, "You better say goodbye to your wife." He didn't know what was going to happen when he said goodbye. Would he be reunited with his wife? So I think really clear, really obvious communication is required in these particular cases, because I think how devastating for that individual to have that occur. And I think probably also demonstrated may prefer information presented in different ways. I think that's also really important too. Intersecting physical health concerns, again, nothing that has really not been shared already by the wonderful presenters. I think really thinking about demands may exceed physical capacity with physical caregiving. But I think it's also really important to know that sleep disorders are also really highly co-occurring in folks with autism and ADHD. And I think sometimes these can be really exacerbated with sleep deprivation. And it's a bit hard when it's, gets to the who is the most tired wars. I think sometimes being able to also look at it objectively and wonder if the people in front of you may also be, challenged by sleep disorders and what is also going on for the sleep in the relationship as well. I think there's definitely executive function differences. I think we've already mentioned managing multiple appointments, and I think there may also be difficulties managing multiple appointments alongside work commitments. I think this often comes up with the dads and the families that I work with, where the social rules are allowed being able to take time off to go to scans and doctor's appointments, and also asking for that requires to stick a limb out, essentially, which might seem easy for neurotypical counterparts, but sort of feeling like they might be walking the line between what's appropriate and not. I think, again, it's already been mentioned, the executive functioning of knowing where to go when baby comes. Potentially dad might be dysregulated if, birth is, happening and underway, and not knowing where to go and then feeling that they sort of are out of their depth. I think when there's multiple children and multiple tasks, I think that can also become challenging too. And I think this is something that probably comes up mostly in my clinical practice, is that demands exceed capacity, and then dad sort of starts to become forgetful, and then he doesn't remember things. And before we know it, mum is telling me that, I've got 3 children, I've got a baby, a toddler, and my husband who doesn't know how to do anything else either. And so I think sometimes it's really important to look underneath that, and is it actually that dad is struggling with his executive function? Dads may also feel overwhelmed at pregnancy rules and paralysed at not knowing how to help a partner, or may also, lean into looking at logical ways of understanding things. Should I take, a partner may say, should I take these medications? And helpfully, a dad might sort of give you all of the logical and rational reasoning as to why you should do particular things. But sometimes this can lead to miscommunications too. I think also holding in mind that dads may fatigue more quickly than neurotypical counterparts. And again, when we're thinking about kind of the sleep wars, who is the most tired, I think sort of being able to give both parts the benefit of the doubt. Even if dad's still getting 8 hours sleep, his nervous system might mean that actually he needs 10 hours to be able to function or, you know, function or respond appropriately to the family. For sensory experiences and overload, I think depending on the dynamics in the relationship for food preparation, I think, sort of holding in mind the diets and how that sort of goes in the relationship. May not be able to have access. He might like to have onion part of his every meal, but now that makes, mum sick. So how do I sort of get around that? I think some of those challenges, Dad may not have the opportunity to acclimatise to new settings or people through appointments. So depending on his ability to access leave or attend maternity ward tours, he might not have his own ability to acclimatise to settings. Sensory overwhelm in medical settings, again, the lights, noise, presence of lots of health professionals, that might also be incredibly overwhelming. But, can't remember what I was going to say, it's gone. And then also sensory overwhelm when the baby comes. So of course, crying, holding baby, changing the baby, and all of the smells and the experiences that are sort of going along with that as well. So I think when we think about all of the changes that occur in the perinatal period, I think this is just so many for both mothers and fathers to really take on. And I think in terms of demands, they may naturally exceed capacity, and we might start to notice symptoms of depression and anxiety emerge. I think probably another thing that emerges in my practice as well is that for my neurodivergent couples, there seems to be a huge co-regulation component. And when you add a baby to the mix, if the dad is not able to access mum for the co-regulation that usually occurs, that can also lead to sort of difficulties in the relationship, which no doubt Ellie will talk about a little bit more. I think it's also really common for dads to feel really lonely in this experience too. I think also thinking about the social landscape of the couple as well, in terms of, what is their social landscape and what would it be like for dad to access social supports outside of his family, because that may not be something typical that he is open or used to doing. I think also reduced functional capacity for dad, and then possible relationship difficulties. So like I sort of mentioned, I think about one of my families, and mum was just like, it would just make it so much easier if he just, sort of cooked dinner every night. And then dad is unable to do that because he spends a lot of time perseverating over the right thing to cook. Is it going to be nutritious enough? And then it ends up being a really big task because dad is really burnt out too. So it's a huge transition with lots of complex demands. And then I think also the social expectations of what fatherhood is meant to be. And I think anger and reactivity definitely become more prevalent. And this is certainly what I've seen clinically as well. So I think for the undiagnosed or unidentified dads that might come across your work, when I think about, I think firstly, it's about including dad in your consultations. And then I think, this is kind of my pattern recognition skills taking hold here. But I think, when I think about, is a dad ADHD or autistic if he doesn't sort of know, if I've got a mum that's sitting in front of me, then who is autistic or ADHD? I think that's kind of like a little kind of mark on the board potentially. I think the MSc in the room is incredibly useful. I'm really able to notice attentional and focus difficulties, particularly when baby is already here. You sort of notice demands exceeding capacity at that point as well. And certainly communication differences, that can also be really clear. I think, you know, if I think of an example, one of my mums would find that if she dropped her baby off at daycare, she would find it hard to sort of, you know, not think of baby because she thought it was, you know, she was really upset, dysregulated, that baby might not be okay. But it was really difficult for her husband to understand that experience and understand that that might be how mum felt. So then, you know, being able to kind of look at that in session and think about, why is that true? How is that happening? And is that a difference in communication rather than dad just not caring or not, you know, being able to look out for the mum? I think there is, you know, I'm not leaning on stereotypes here. There is published evidence around career choices for autistic and ADHD dads. They often work in STEM fields. So you might find that you have a dad that works in a STEM field, and sometimes that's really helpful data to collect. I think mums will often talk about their partner's schooling history. There's been lots of dads that have been diagnosed as dyslexic through their schooling, and we know that there's a high co-occurrence of dyslexia and ADHD and or autism. So sometimes that might also give us a clue that dad is ADHD as well. And mums will also share the mental health history of their partners because that's relevant to them in terms of if dad has had struggles in the past or current struggles. So often I think it's relatively straightforward if dads are included in practice to sort of see what needs to be done, or to see if dad might need extra accommodations. Interestingly, I sort of also have a bit of a hypothesis that dads also find it a little bit like body doubling therapy, in that if they can come in with mum and speak to someone that's able to hold the whole family, they are able to feel seen. And I think it sort of helps them with the building relationship element. But of course, sometimes it makes it hard to get dad out. So that's probably another problem I end up with, is that they want to stay for longer. So, what do we do if we are working with mothers? And I think it's about inviting dad in at any and all stages. And you know, I think, of course, thinking about safety for mum and also thinking about your own safety as a clinician. But for the most part, I have not ever had a dad decline to come to session. And for the most part, it's always been really helpful to gather more data. I think it's also really helpful, particularly if mum is in a chronic depletion, like Amy has spoken about this morning, dad feeling like he has got a helpline to you or is able to talk to you about what your observations are in session. So that is a regular part of my practice, is that they know that they can contact me if they have concerns. And I think that relationship safety is definitely important for that. I think really observing and listening to what is going in the relationship with dad as well. Again, is it that dad, you know, is not capable of doing some of the things around the house, or is it that he's burnt out, or that he might need scaffolding or support? Let's think about him for, you know, from a compassionate lens, that he's just, you know, no good. I think that is really helpful. I think also including dad means that, you know, I had a dad sort of say, it feels like you want our family to stay together, Sarah. And I think that was a really important piece of feedback for me, because that's genuinely what I feel. I feel that all parents are really trying their best and that's what they want. And so being included in care is really important. I think probably from this conference, you will gather that fine-tuning clinical skills around identifying ADHD and autism is really important. Again, I don't think it's essential that parents are diagnosed or identified, but I think being able to recognise some of the vulnerabilities that we've mentioned can really contribute to practice. I think also having some great neuroaffirming supports to refer dad to if needed, because I think that can also help. He might need to access his own supports or own help. But I also, once, you know, if dad is able to find their own neuroaffirming clinician, I also try to keep dad engaged in treatment, because again, I think, you know, the family will continue to grow and challenges will change over time. I think if you're working with dads, I think something that's really important is knowing if they are self-referred or referred by their partner. I think sometimes, a partner might say to me, it feels like I've got a third child. I want them to go and get some scaffolding and support. And in terms of the support that they access, it might be support for a neurotypical adult or a neurotypical man. And then it sort of actually exacerbates the relationship difficulties in the relationship. So I think sometimes it's understanding who is the one that is engaging in treatment and actually thinking about it holistically and thinking about perhaps I need to invite mum in to understand what's going on in the relationship before, getting dad to get outside more or take more walks or behavioural activation, which might be treating something completely different. Again, I think fine-tuning clinical skills of identifying both ADHD and autism as well, I think is really important as well. I think another really important piece of the work that we do as well is validating dad's struggle outside of mum's, and recognising that they are allowed to struggle. Again, sort of thinking that a bit like the sleep wars, who is the most tired or who is struggling the most. I think holding space that actually dads can struggle too. And perhaps if we can support both, that we can support the child and we can support the whole family as well. So for support in terms of my practice with dads and mums and families, I really am very explicit in terms of scaffolding and planning around the perinatal period. And I collaborate with all and any health professions that are involved in their care. So in terms of, I think we spoke a little bit about I hadn't heard of birth mapping before, but that is probably a common practice that I use. We really speak about birth options, how dad can advocate, what can happen here. And so there's a lot of that pre-planning that happens when potentially they're more regulated than when things are happening in the birth suite. I think also providing explicit instructions for dad when baby is born. And then, of course, these are always recalibrated as needed. So if, mum had planned to have a vaginal delivery and then had a Caesar, potentially dad might need to do more of the driving for the first 6 weeks. So how can we kind of manage that? I think also including dads as part of psychiatry care, but then also having it on the record or having it on the medical records, like Julie suggested this morning, that there are neurodivergent families or dynamics so that they can sort of hold that in mind. I provide lots of opportunities for questions and answers, so no silly question policy, and I seek out opinions when required. I had a beautiful dad said to me, "Am I allowed to do skin to skin?" And I thought this was right at the end of the pregnancy, and I, really felt for this day because I thought this poor dad has probably been wondering this whole time and felt like he couldn't ask anybody if he was able to do that. And so I think there will be lots of things, well, we might sort of go, well, isn't it kind of obvious that all parents can do it? But actually there might be lots of questions that they need explicit support around. I'm always more than willing to provide leave notes for dad. If I see that mum is struggling and dad needs to take time off work, I'm more than happy to provide those certificates. Again, for support, I like to encourage family involvement where safe and appropriate. So can mum come and take baby overnight, or can dad do X, Y, Z? I also, where resources are allowed or available, I try to scaffold families to outsource whatever they can afford or feel capable of outsourcing, which may include cleaning, meals, washing. I've had families use night nannies, whatever feels safe and reasonable for them, so that they can spend all of their time regulating and attuning to what they need in the moment. And I think it's important I monitor the overall well-being and health of the family, and call in more support as appropriate. So I'm always looking for local supports that are affordable as well. So for groups or opportunities for neurodivergent families to connect with other neurodivergent families if that's something that they would like. There are times where I've had a dad who I think would really benefit from diagnosis and treatment, particularly for ADHD. And I think, it is my role, even though they are not my patient. I can see that it would benefit the whole family. So I think sometimes scaffolding that and supporting that is also really a significant thing for the family if I can. And then we're able to sort of monitor that and make ways for that to so that they sort of feel well understood. So I think when I think about back to this quote, which I sort of highlighted at the beginning, I think remember a father's involvement is possible when there's sufficient motivation. So I think motivation, particularly when I think about ADHDers, are they burnt out? Have they got the capacity to initiate tasks? Do they need access to stimulants? Do they need, social supports? Skills, have they been given explicit skills around how to support their partner, support their baby, or become a father? Self-efficacy, do they feel like they can do things well? Are health professionals telling them that they're doing a good job and they're including them like they have something to contribute to the child rather than just assuming that they don't have anything to contribute whatsoever? And social support, again, so thinking about us as health professionals, supporting dads as well, in conjunction with an absence of institutional barriers. So thinking about us as healthcare providers, again, making sure that we are including dads as part of our service, because including dads supports the whole family. So I think to conclude my fast talking, not enough is known about dads in general. And due to their importance in the family and their changing roles in society, I really don't think that's good enough. I also believe that dads feel invisible in perinatal settings, yet they really need to be seen by us. I wondered why so many dads wouldn't leave practice once they were included with me, but I also wonder if it was the first time that they felt like they had something to contribute. When I think about all of the healthcare professionals that are involved in the bringing of a little person earthside, I think that's quite sad. Barely anything is known about autistic and ADHD dads, yet they exist and are likely presenting more often than we know. And we need to see these dads and explicitly scaffold and support them through the fatherhood transition because it helps everybody. And to borrow from Ross Green, who sort of says kids do well if they can, I also believe that dads do well if they can. And they can be a really great source of play and enrichment. And if they can support the mothers, I think that also makes a really big difference to the family too. And so that's it for me, Bronwyn.
Amazing. Thank you, Sarah. Let's rest on the next slide if we can. And your presentation, Sarah, honestly is such an important reminder and a call to action, which is our part of our vibe, isn't it? The calls to action for all of us to hold dads in mind, to include them, to look out for them, and to wonder and assess whether they may be presenting during the perinatal period with or as autistic or ADHD. Sarah, tell me, uh, if a dad is unwilling to be involved or included and there's some resistance there, like I noticed in your presentation, you said you've had a 100% success rate with inviting dads in. So two questions in a way, like one question is, how have you had that success? I'm curious about that. But also for others working perhaps in different settings, if there is an unwillingness to be involved or included, where does one go? Because we don't want to just kind of stop there if it's a dead end. We want to look for other pathways, right? Could you speak to that a little bit?
Yeah, of course. I think, and so again, I think this is really important about the clarity of our communication and being really clear. I think in terms of inviting dads in, potentially when I think that they might be neurodivergent, I think being really explicit that I'm not going to get them in and tell them that they're doing a terrible job and they're awful and, they need to be reprimanded for they're not being a good enough father. So I think really the way that I communicate it is that I really would like to meet them because they are an important part of the story. And generally, my goal of getting them included is to make sure that the family is going okay and see how things are going from their perspective. But also, and it's not really under a ruse, but really, how can I get them in to support the woman or my patient? So I think being really explicit about that. I think
Mm,
also making it accessible. So I think there are also dads who I do home visits to Bron. And so
mhm,
if a dad leaving home or with the baby, that might be too much of a challenge. So if it's about accessibility, how can I accommodate that, or how can I sort of make that happen? Again, around, work, if dad is back at work and it's too much of an executive functioning challenge to arrange coming to a session while also work. Again, how can we sort of make that happen?
mhm,
Well, relatively flexible with timing in the way that I go about that as well.
mhm,
That's
mhm.
ability in practice. So I
So we
think,
have to think creatively in that way, don't we? Like it's not just one route, it's what are the various pathways that we can, yeah. Mm-hmm.
yeah, absolutely.
Mm-hmm.
And I think if dad is unwilling, I think that also gives us some really good data too.
Mm-hmm. Right.
It gives us some good data about, mum and how much, potentially she's having to overfunction. What is her, what is dad's understanding about mental health? What is dad's understanding about psychology? Does he
Mm-hmm.
fear psychology? Does he fear
Mm-hmm.
psychologists? Or, whatever your health profession might be.
Mm-hmm.
Or, is it that he's, struggling to a capacity himself?
Mm-hmm.
So I think it gives us good data to wonder about, actually.
Mm-hmm.
Yeah.
Mm-hmm.
Mm.
I'm just adding to this conversation too with my what I hold in my own mind from Richard Fletcher's work, which is about making, he says, to make the purpose clear. So being
Mm.
transparent, which is what you spoke to, and to pitch the benefits, whatever the benefits might be to dad, but also the family unit. So for those of you who are thinking about how do I engage dads, um, transparency, make the purpose clear, and pitch the benefits across the board is a good way to go. Yeah. Yeah.
And I think probably like, everyone else has spoken about, it's about being warm, relational,
Hmm.
not going straight to the clinical daggers. It's about, understanding a little bit about dad and spending, creating that space to have that sort of safety and relationship as well.
Thank you.
And
Sarah, a question has come through on the chat
mm,
asking, are there any ND affirming resources that you recommend to fathers who you support, who you suspect are neurodivergent?
so I haven't used any resources, and
Mm-hmm.
I think the important reason is that Bron might relate to this is there actually is nothing.
Yeah.
And so in terms of finding some resources, I'll just see, or you might have control now, Bron, but at the end of my presentation, there's a couple of web pages which, you may be able to share or access with Dad. I think also, so yeah, I mean, they're only sort
Yeah.
of more recent to me in
Yeah.
preparing for this presentation.
Yeah.
Otherwise, it's mostly verbal or it's
Mm-hmm.
mm, through mum. So usually the beautiful part if mum is starting to self-identify or becomes diagnosed is they sort of get an education by proxy. So I think that can always be quite helpful. But yeah, I think there's so much to be developed and done in this.
Yes.
So
Yeah.
not yet.
Yeah. 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 So, Sarah, final point. If people are looking to focus a little more on dads and include dads, where could they upskill a little bit more other than here? Where else can they upskill?
Hmm. So I think this also requires a bit of flexibility in our own approaches too. So to think about, um, including dad, you don't know what's going to happen. You don't know what's going to happen when they turn up. Um,
Mhm.
and, in terms of, it's a bit like that TV show, Thank God You're Here, anything can happen.
Mhm.
And sort of, it might be around accessing some supervision around, how can I manage that, or what would that be for me, managing those kind of social arrangements where they come in and, I'm not quite sure what the purpose might be, or I'm not sure how to manage.
Mhm.
And I think, but also, so I think it's probably supervision. I think it's probably speaking to other folks that are doing father inclusive work.
Mhm.
I'm
So
trying
there
to.
are other symposiums coming up as well, like the Fatherhood Research, the Australian Fatherhood Research Symposium, if people are interested in
Yeah.
hearing about research across the board for in the fatherhood space.
Yeah.
Yeah.
Um, Absolutely. Yeah, I forgot about that. And then there's also some wonderful dads organisations around, and Bron and I are speaking to them about having some neurodivergent resources, including SMS for Dads,
Yeah.
and dads groups.
Yeah.
And they've sort of indicated that the demand is there, but they
Yes.
haven't put any of that stuff into action. So hopefully, over time, there'll be more for people to access.
Yes. And with regard to the neurodiversity affirming resources as well, to that question, this is very much in the pipelines. I think it's okay for me to let people know, but our Speaking for the Baby campaign, we're doing a collaboration with SMS for Dads. So we're doing a whole arm of Speaking for the Baby illustrations with that are dad baby centric. So they will be, I imagine, quite helpful resources for our autistic and ADHD folk, because they're, the visual representations of positive things that fathers can involve themselves with their baby. So, yeah.
And Ellie's just, of course, mentioned Becoming Us training. Of course,
Yeah.
Ellie.
Yes. So let's get Ellie in the hot seat now. Sarah, thank you so much for your presentation and answering those questions. Our next speaker is Ellie Taylor, with over 25 years experience as an emotionally focused relationship counsellor, parent group facilitator, mental health educator, partner and mum. Ellie Taylor has become an internationally known parenthood preparation and perinatal relationship expert and the award-winning author of Becoming Us. Ellie's passion is preparing parents for a happy and healthy family. Her Becoming Us approach includes fathers and partners in all aspects of pregnancy, birth, and beyond, harnessing the attachment bond between couples to stabilize them through the life changes and unexpected challenges that come with parenthood. Today, Ellie is speaking with us about navigating neurodiversity in perinatal couple relationships. Welcome, Ellie.
Oh, thank you, Bron. It all sounds so good when you say it.
Right?
I don't know. I sound more impressive with your voice. I don't know why.
But you are impressive, and we're glad you're here. Welcome.
I'm just going to click my slide and hope that, okay, I've clicked and I'm waiting and I'm not getting my next slide. Okay. Doesn't seem to be working. There we go. Okay. So, hi everybody. Thank you for having me. I am so grateful to Bronwyn for pulling us all together for this really, really important conference. I've been waiting for something like this for 10 years. So, like, I've just got so much admiration for Bronwyn for being really proactive in this space and bringing us all together. I'm going to start with a disclosure. This is actually the first time that I've presented on navigating neurodiversity in perinatal couple relationships, and it is a topic that is very close to my heart, as will be shown, I guess, throughout the presentation. It's based on pretty fresh lived experience, actually, or some of it is. So I'll introduce myself a little bit more and then we'll dive in. Okay, so a little bit about me. My background is emotionally focused therapy. I was an emotionally focused therapist for about 25 years for a not-for-profit called Interrelate here in New South Wales. And I became a new mother at the same time I became a relationship counsellor. So it was always with a very deep and special interest in the perinatal period. And it was working with clients with that focus that I ended up with a whole bunch of stuff in my head for a couple of years. I eventually spewed it all out into a book, which was published by HarperCollins here in Australia in 2011 called Becoming Us. After that, I was offered a column, a relationship column in Practical Parenting magazine, which I wrote for about 4 years. And I'm honoured to have been on the advisory panel as a perinatal relationship subject matter expert for a number of university research projects, including SMS for Dads, which was just mentioned, supporting your partner when you have a baby through the Australian Catholic University, Monash University's emotional experiences of early parenthood, and most recently, the Birth and Corona project through Columbia University in New York. I've got two big influences, I suppose, that I like to give a shout out to. One is Kent Hoffman, one of the co-founders of Circle of Security, and the very sadly missed Sue Johnson, who's the creator of emotionally focused therapy. And I had a little thrill sort of fairly recently when Becoming Us was recommended alongside a couple of Gottman books by Karen Kleinman in her book, What About Us? So it's nice to get that recognition. Okay. What I also will tell you at this point is that I am neurotypical, but I've lived with neurodiversity my whole life. My mother is undiagnosed but self-identifies as being autistic. And my dear darling husband, who I have been with for about 40 years now, was diagnosed 2 years ago with ADHD, finally, and after a lot of struggles. So I really was listening to Sarah's presentation with a lot of heart and, you know, some regrets that we didn't have the sort of support that she's talking about 30 years ago when we started our family. Okay, let's dive in. So I was thrilled when Bronwyn invited me to present on this topic, but also had a little bit of a panic attack because relationships by themselves are quite sort of complex, let alone layering anything on top of that. So I'm going to try and sort of tease it all apart and talk to you about navigating couple relationships to start off with, then navigating neurodiversity in couple relationships. Then we're going to talk a little bit about navigating perinatal couple relationships, and finally I'll attempt to bring it all together. But you can be the judge of how well I do with all of that. But it is a challenge in a couple of hours, let alone less than an hour, but we'll see how we go. Okay, so let's start navigating couple relationships. Well, couple relationships are both complicated and complex. And so I've worked with a lot of psychologists, trained a lot of psychologists over the years that will say things to me like, I'm terrified of seeing couples, or if I had a dad in the room, I'd like that, but I wouldn't know what to do with him, or it's just all too hard, it's all too overwhelming, it's all too scary. And I get that. And there's good reasons for feeling that way. So relationships, the difference between complicated and complex, I guess, are in the nature of the issues that are coming in the door or being presented to us. So complicated problems tend to be specific. They're often external challenges, but they're solvable with established rules and processes. For example, different expectations, different communication styles, or a history of unresolved conflict. These are kind of, I guess, in some ways, surface differences that can be identified, addressed one at a time, and kind of worked through. We can take kind of a problem solution approach to complicated issues. Complex issues, on the other hand, are the sorts of things that relationship counsellors typically see. They're not easily solved with a single approach. They require understanding of the interplay of many different factors. They might not be easy to make sense of. They might not be easy to articulate for either the clients or even for us as care providers. They might not be easy to explain. They might not be easy to find words for. And this can include things like trust issues, cultural differences, hidden concerns, or lingering traumatic experiences, and of course, neurodiversity. These issues are not problems to be solved. These are deeper differences to be respected, to be explored, to be untangled, and to be facilitated or worked through. And you may or may not have capacity to do that in your role, and I recognise this. I know that we've got a lovely diversity of people here today. But let me give you an example. Hopefully my slide will work. Yes, yeah. So relationships are layered. So for example, we might have a surface issue, which is some sort of disagreement. So I said I'm leading with lived experience in this presentation. So let's go with being on the phone all the time or always on a screen when we're together. So that might be the surface issue that somebody comes in with, okay? But underneath that disagreement about screen use, there might be hidden issues like loss and grief. I miss who we used to be, a loss of identity. I miss feeling seen and wanted by you. It might be relationship closeness. I'm worried that we're drifting apart. Unspoken resentment or guilt. I'm carrying so much right now and you seem to be checking out while I'm just drowning. It could be disappointment or disillusionment. This isn't how I thought our life would be at this point. It could be unacknowledged stress or trauma. I don't even know how to talk to you about how hard things are for me right now. I'm barely holding it all together. And then even below that, there could be what I call hidden concerns. And these are things like, am I good enough for you? Do you even see me? Or will you support me when I need it the most? And so that we've got these layers of relationships. Some of it we can see above the surface. Some of it we might be able to see below the surface. But it's often likely that our clients are even less able to see some of it than we are. Or they see it, but they don't want to disclose it. So there's all this complex interplay of factors, which is what makes relationships so complex. So here I want to, and I press too quickly, introduce to you the notion of wayfinding. And wayfinding is finding your way when you're actually not really sure where you're going. And it's something that helped me to find my way working through with perinatal parents when I didn't have a map. You know, I'd read all the books, I'd done all the training, and I still didn't have what I felt was specific enough or supportive enough for the perinatal period to work with my clients, which is how kind of, I guess, Becoming Us was born. For wayfinding, we need two things. One is a compass, and then the second is a general sense of direction. But here's the thing, in relationships, there's actually two directions that we are looking for. So the first is a vertical, I guess, a vertical direction, and that's power. And so that might bring up questions if we're looking for it, like what does the balance of power look like in this relationship? Who has more power? Who is on top? Who has less power? Who is on the bottom, if you think of a seesaw? How big is this imbalance? You know, is it this big or is it this big? And how does it show up in this relationship? So that's the first direction that we're looking for. The second direction is a horizontal direction, and that's intimacy. How close or distant are these partners or this couple with each other? Are they moving closer or are they moving further away? What's changed, when and why? What's their capacity for going deeper to a deeper level? And where are they getting stuck? And so this is the intimacy direction that can inform our work with couples, and it certainly does for emotionally focused therapists Often the question, what's changed, when and why, is one of the first questions a relationship counsellor asks in a session with a client. And 99% of the time, if the couple had children, it would be after the birth of their first baby. That was really the demarcation point when we could see that things really shifted in terms of both power and intimacy. But I'll talk more about that in a bit. Okay, so just as trauma-informed thinking has really opened up opportunities for a deeper level of perinatal preparation and care, so too, I believe, can relationship-informed thinking provide new opportunities and a way forward. And relationship-informed thinking involves the knowledge that relationships are processes, relationships are systems, and relationships require mutual growth. And I'll talk through these one at a time. So, relationships are a process. When you think about it, a date is a process, making love is a process, an argument is a process, relationship breakdown is a long series of processes, and so is relationship improvements. And the great thing about processes for me, who is passionate about prevention and early intervention, is that in processes, we've got lots and lots and lots of opportunities to intervene if we know what we're looking for. If we can see a curve coming up or a curve that's just occurred, we know that we have an opportunity to maybe reroute couples as they travel. So a process orientation means focusing on the journey of becoming a couple or becoming a parent, not just the outcomes, not just the milestones or the solutions to problems, but the dynamic, evolving experience of growth, adaptation, and relationship development over time. A process orientation means focusing on ongoing growth. So rather than viewing change as a series of fixed steps or checklists like achieve attachment or avoid conflict, a process orientation really recognizes that emotional and relational development can happen in waves, and it often does, or even in cycles, as I've identified in Becoming Us, that there's ups and downs and learning curves, that parents are always becoming, not just at birth or as marked by milestones, but across the whole transition to parenthood and beyond. And I've worked with couples who have been together for 30, 40 years and who now have grandchildren who are still grappling with early parenthood issues that had come between them 20, 30 years ago. It stays with you. It's such a vulnerable time, can be such a traumatic time, that this stuff stays with you no matter how long you've been together. A process orientation means seeing parenting not just as a role to perform, but as a shared relational process. Parents are growing as individuals and also together as a couple, and the couple's relationship is evolving, and how they navigate that process of evolvement affects the whole family system, which I'll talk about next. So a process orientation means emphasizing awareness over quick fixes. It's helping parents react on what's happening in real time, naming feelings and patterns as they arise, and making meaning of experiences rather than trying to fix themselves, the problem, or their partner. And again, this may or may not be within your capacity for working. Finally, a process orientation supports building emotional literacy and connection. And in practice, this might look like encouraging open, honest, and curious conversations, holding space for uncertainty, for grief, for joy, and for love to all coexist within moments of each other sometimes, and helping couples recognize that disconnection is a normal part of the process, and reconnection and repair are always possible. I think I should be Italian because I use my hands a lot. And if I had to describe what perinatal couple relationships look like, I would say it's something like this. That's also my Venus Bananarama Bananarama dance. I've just realized. Okay. So whenever you hear Bananarama Venus, you can think about this couple's work. Okay, relationships are also systems. And systems thinking, I guess, is a way of understanding and conceptualizing the complex and interconnected nature of relationships and family life that we're talking about. It means looking beyond individual experiences or behaviors and seeing how relationships, roles, environments, expectations, and all of the rest interact as a dynamic, evolving thing. Systems thinking recognizes that each person, the partner, the baby, extended family members, affect and are affected by the others. That changes in one part of the system ripples throughout the whole. For example, a mother's, father's, or parent's mental health, whether it's anxiety, depression, OCD, whatever, is going to influence the partner, the baby, and the relational climate in the home. The family system includes both visible dynamics, like we've said, like communication and behavior, but also invisible forces like cultural beliefs, emotional patterns, and expectations. The perinatal period is a key developmental window, not just for the baby, but for the couple and the system as a whole. And so system thinking helps us to see how individual struggles, for example, postnatal anxiety or depression, are connected to both closer relational and wider social factors. To understand that healthy families doesn't mean there's no conflict, but that systems can adapt and can communicate to each other and can grow through change. It's also, systems thinking also helps us to intervene in ways that strengthen the whole family, not just the individual. And I love how inclusive you now will all be after Sarah's presentation, and including the other single most important person in this whole brand new system, which is dads and partners. So systems thinking encourages us to have curiosity, exploring what's happening with this system rather than what's wrong with this person, as has so often happened in the past, particularly with neurodiversity. Take a preventive focus by supporting relational and emotional foundations. Early on, as early as possible, we can build resilience into the family system before problems escalate. And systems thinking also encourages to be part of collaborative care, working across disciplines and with the whole family unit, not just the identified patient. And I love how much I am hearing the words whole family being used, even just in the last few years. Is beautiful to hear. Okay. Both a process orientation and systems thinking support growth. There's no getting away from it. Becoming parents takes a couple's relationship to a whole new, deeper level. Sometimes it takes them to rock bottom. And that was the case for my partner and I, partly because of his neurodiversity. I heard Sarah mention that couples where there is neurodiversity will struggle more in the first 12 months, and we certainly did. So I really kind of identify strongly with that. But rock bottom's not such a bad thing if you've got structures and frameworks and scaffolding and support to work your way back up. And that's what I hope that this presentation will leave you with, if nothing else. Okay. So let's talk now about navigating neurodiversity in couple relationships. We talked about two compass directions, power and intimacy. Well, how do they apply to neurodiversity? And I'm going to tap a little bit more into my lived experience here and speak to this as a neurotypical partner with a partner who has ADHD. So there can be a power imbalance. Oh, sorry, next slide. Okay, so there can be even more of a power imbalance in neurodiverse relationships. And this can show up in subtle and complex ways, shaped by differences in communication, emotional processing, and also social perception. And so some key patterns in how it might manifest, which it often did for us, are in our communication styles. So neurotypical dominance, I suppose. As the neurotypical partner, I might unintentionally set the standard for normal communication, which I did for a very long time. I might expect eye contact from my partner. I might expect him to modulate his tone or respond to me quickly when I disclose something. But when my partner struggles with some of these things, his views might be dismissed or misunderstood by me, and they certainly have been. Then there's misinterpretation. My neurodivergent partner might be more literal or direct, which I can see as them being blunt or insensitive. And again, guilty. If I assume malice or lack of empathy, I might take the position of authority in defining what really happened when we go over it. And oh boy, did we go over it. We did lots and lots of do-overs. Power might show up in our emotional expression. So as a neurotypical partner, I might express emotions in ways that are more socially recognized or validated, like crying or venting to girlfriends or whatever, while my neurodivergent partner might shut down and mask or seem detached. I might misread this difference as emotional immaturity or avoidance or stonewalling, to use the Gottman term, when in fact it's and that gives me more influence in emotional decision making, when in fact it's a protection, it's a self-protection mechanism that happens for them automatically. In terms of decision making and control, as the neurotypical partner, I may take on more control in daily decisions, assuming that my way is the more functional, or again, the more normal way, or maybe the easier way, or maybe the more socially acceptable way. But over time, this can then lead to my neurodivergent partner being excluded from decision making or doubting their own competence. And I know that that's something that he's disclosed to me. In terms of social navigation, as a neurotypical partner, I often have more ease navigating social systems. I would tend to take on the responsibility with the parent-teacher meetings, with the extended family, with healthcare providers, with appointments, that sort of thing, and become the spokesperson, I suppose, or the default authority, even in areas where my partner and I have equal stakes, which is everything to do with our children. And then this can enforce those unequal dynamics, especially when my neurodivergent partner is spoken for rather than with. And again, that's something that we've needed to work on. Pathologizing differences is the next point I want to make. And in the past, that's something that I have framed my partner by as a problem to fix. I've even externalized the ADHD and other things that we've been grappling with, thinking that I was doing the right thing, but it still put us in an unequal position. And kind of meant that I had to put in less effort to really understand what was going on for him and what his reality was. So that's something that I've had to learn to do just in the last couple of years. And that created a real imbalance, I guess, in how we approached our issues. So my neurodivergent partner probably felt like he was more a project or worked on, something to be worked on by me. While I tended to maybe escape a bit of scrutiny in those situations. And in terms of therapy and professional support, that's probably where it actually showed up most. So therapists unfamiliar with neurodiversity may unintentionally align with my neurotypical worldview, which further marginalized my partner's experiences. And that did happen for us, and it delayed our help seeking or further help seeking by quite a few years. From a relationship counselor perspective, I can completely understand that. I know that I worked with some clients that I was it was easier for me to identify with and empathize with. I think that's just a natural human trait, but good for us just to maybe, you know, be aware of that and to make a bit more of an effort with the partner that we're less comfortable with or less familiar with, as I've had to do in my own relationship. So again, that you know, professionals identifying more with the neurotypical or the neurodivergent partner, if you're neurodivergent yourself, is another way of unequaling that power balance, I guess, between you and the partner that's may or not be there. Then also there's a power imbalance often in the masking and burnout for neurodivergent partners. If they have to mask to fit into the relationship, that means suppressing their own needs, their own natural behaviours. And over time, this can lead to emotional exhaustion that Sarah spoke about earlier, resentment on both sides, and a sense of invisibility. And I would say that that's on both sides as well. But I can remain more unaware of the toll on my partner, maybe than he is of me, because I'm more vocal about it. But again, any imbalance, it doesn't matter which way, is going to cause more problems and more likely cause problems that escalate. It doesn't matter where the imbalance is. So to take a relational approach to rebalancing power in neurodiverse relationships, both partners and their care providers need to recognize that difference is not deficit. And this has become kind of like a mantra for me. And I'm sure others have mentioned it over the last couple of days, that difference is not deficit. Difference is not deficit. Mutual respect, curiosity, a shared language for needs, hidden concerns, and boundaries can really put both partners on, I guess, a level playing field. So rather than seeking sameness or even agreement, or even, you know, even understanding, the relationship can grow by creating a third space or a middle path, which is one where both ways of being are respected and honoured and given space. Okay, so that's power, which is our first compass building direction. And now we're going to talk about intimacy. So problems with intimacy in neurodiverse couples, again, emerge from differences, not deficits or deficiencies. These differences, especially when misunderstood by a partner, which I often did, or unmet with compassion, which again, I often did. I often took a lot of this stuff personally, I have to say, and got defensive. This can lead to emotional distance, frustration, and often deep hurt for both partners. So some common ways that intimacy challenges show up are in different needs for connection. So as a neurotypical partner, I craved emotional closeness, especially as I was an emotionally focused therapy and I was giving out emotionally to my clients all day. I craved emotional closeness from my partner through talking, through eye contact, through sharing feelings, while my neurodivergent partner might feel closest through shared activities, through sitting next to each other on the couch without any pressure to talk, especially at the feelings level, or through just giving each other practical support, which were his, I guess, love languages, if you like. When these needs aren't recognised as different but equally valid, each of us can feel unloved or inadequate. So let's talk about sensory sensitivities. Physical touch that's comforting for one partner might be overwhelming or irritating to the other. Hugs, cuddling, sexual intimacy can become areas of tension if sensory preferences aren't openly communicated about and respected. These are difficult conversations to have. So if you're working as a psychologist with additional training in couple dynamics or as a relationship counsellor, thank you for initiating these conversations with your clients. It's much easier when these conversations are initiated by a professional and the couple can then just go home and continue the conversation rather than starting the conversation. It's often the starting that is quite challenging. So I really appreciate the work that you're doing in this space. So if it's not being communicated, or it's not able to be communicated for a whole bunch of reasons, a neurotypical partner can interpret withdrawal as rejection, or the neurodivergent partner can feel pressured to perform. And intimacy can quickly become a source of anxiety for both of them rather than a source of bonding and pleasure. Then emotional misattunement was a big issue for us that we also are continuing to work on. So my neurodivergent partner might not recognize subtle emotional cues, or may take longer to process emotional information. And I can perceive this as a lack of empathy or emotional distance. Conversely, I can be flooded with emotion and I can seek immediate reassurance from him, or connection from him, which can then feel overwhelming or confusing to my neurodivergent partner. And then this can create a cycle of disconnection. I need to pause at this point and let you know that since my husband was diagnosed 2 years ago, and we've both had individual and couples therapy and medication and love it all and appreciate those of you that are doing it, he has now become a very vocal mental health and lived experience advocate. So he has given me permission to share everything that I'm sharing with you. I just got halfway through and thought, oh, I forgot to mention that at the beginning, and I'm sorry, but he's so supportive now. He talks about this openly with his crew. He's a station officer at a fire station. He talks about it with his mates down at the surf. He's very vocal and open about it, as am I. And so these days I'm really living with my lived experience now that I have permission to do that from him. Okay, so back to intimacy. Thank you. Back to intimacy. So difficulty with vulnerability. Like, vulnerability is the space that I live in, right? That's my bread and butter. That's where I'm actually most comfortable, is talking and inhabiting vulnerability. But for my neurodivergent partner, emotional vulnerability feels really unsafe, unfamiliar, and he used to protect himself by staying factual, by deflecting, or by avoiding emotionally charged conversations. I've often, as I mentioned, interpreted this in the past as him stonewalling and being emotionally unavailable, when actually for him it was a form of self-regulation or fear of being misunderstood. And interestingly enough, for both of us, medication made the biggest difference here. So before medication, my husband would say that he had so many thoughts swirling in his head that he couldn't land on one long enough to identify any sort of feeling that's related to that particular thought, let alone access any deeper feelings, as we've spoken about the layers of hidden concerns and feelings. So he would be up here. Me, as an emotionally focused therapist, I would be down here, and I'd be like, yeah, but what about like down here? And kind of trying to tug him down, so that we could connect at a deeper level. And it wasn't until he started on medication that he was able to go through that process of identifying a thought, identifying a main feeling or a surface feeling, but even staying with that main or surface feeling to get down to the deeper, more vulnerable feelings, which is what the emotionally focused process really is all about. And to kind of work his way down, if you like, to that level, at the same time that I was kind of working my way up to meet him there. So medication, huge fan. It really did. I really save our marriage, I suppose. I have to say that. Okay. So also too, talking about, let's talk about intimacy. Let's talk about misalignment in sexual intimacy. I'm not going to share too deeply here from my lived experience, going to respect that boundary. But differences in libido, sensory preferences, or communication styles can make sexual intimacy challenging. So neurotypical partners might long for more verbal affection or romantic gestures, while neurodivergent partners might prefer clear, direct cues and find unspoken expectations confusing or stressful. If either partner feels pressured or rejected, trust and safety in the sexual connection can erode. And I'm just going to leave that one there. Social and emotional burnout is the other point that I wanted to speak to in this section. So for neurodivergent partners, masking social exhaustion or overwhelm can deplete energy for intimacy. If rest and recovery aren't built into the rhythm of the relationship, one or both partners might feel emotionally or physically unavailable. So managing intimacy in neurodiverse couples, in neurodiverse relationships, requires translation, trust, and tuning in over time. Not trying to be the same, but finding shared ground or that middle path where differences are honoured, inviting curiosity over judgment, slow navigation over quick fixes, and a belief that connection doesn't have to look one way to be real and meaningful. And that's been a big lesson for me. Okay. Now we get to the best bit, navigating perinatal couple relationships. There's a couple of things that you need to know at this point in the presentation. And that the first is this. This is the becoming us stuff. This is how becoming us was born, was knowing these next two things. The perinatal period is a time of diverging paths for all couples. So we know from research that a whopping 92% of all couples, regardless of their neurodiversity or other factors, will report increased conflict and differences in the first year after baby. We also know that 67%, and this is Gottman statistics, 67% of couples report decreased relationship satisfaction in the first 3 years after family. So all couples go through a process. We're talking about processes. All couples go through a process of growing apart when they become parents. But, and I hope that the birth professionals, the midwives, the obstetricians, maybe if you're here, doulas or maternal professionals might appreciate this. The perinatal period, and this is very, very exciting, is also a window of opportunity for all couples. So we've got the opposite of what I just spoke about. So from decades of attachment research, we know that while adults may grow up with an original, maybe insecure attachment style, that through forming healthy relationships over time with siblings or aunts and uncles or teachers or girlfriends or boyfriends or grandparents or whatever, they can earn secure attachment. So couples come into adulthood potentially with earned secure attachment, but if not, with the capacity for earned secure attachment. So even if they have an insecure attachment style, they have the capacity for earned secure attachment. And interestingly, so that earned secure attachment we knew back in 1994. It was coined by Pearson and colleagues when they did the adult attachment interview, which I'm sure the psychs here would be familiar with. But then in the early 2000s, a different area of research into neuroplasticity and hormones and more medical stuff, Walter Freeman was a professor at Berkeley University, and he did some landmark research on the role oxytocin played in adult bonding. And he found and posited and hypothesized that whenever adult partners have a period where there is new oxytocin or oxytocin flooding in, which is at 2 times in an adult's life when they fall in love with a new partner and when they become parents, there's huge potential, a huge window of opportunity for more secure adult partner bonding. And that for me was, wow, okay, how do we facilitate this? How can midwives facilitate this in their role? How can obstetricians, if they're doing that in their role, facilitate this? How can antenatal, maternal, mental health, social work professionals help to facilitate this? And I believe everybody can play a role in facilitating this. to usher adult partners over the threshold into parenthood in ways that supports the bond between them. Because when we support the bond between partners, we're also supporting parent-infant bonding, or what I call whole family bonding. And again, I'm delighted to see that terminology is being shared. Okay, so we can support parents and couples with anticipatory guidance, frameworks and skills that orient them towards more secure attachment. This is the third space. This is the middle path. This is the crucial missing part that I see in a lot of places and a lot of, spaces. And applies to all couples, but particularly to neurodiverse couples. So knowing all this, we now get to navigating neurodiversity in perinatal couple relationships. Let's talk about a relational approach to managing communication differences, executive functioning, sensory experiences overload, overwhelm meltdowns, and autistic burnout, intersecting health conditions and experiences of pain. Alrighty, so a relational approach to communication differences. This, I guess, focuses on the quality of the connection between partners rather than trying to fix or normalize individual behaviors, as I've mentioned before. This perspective honors each person's unique neurotype and works really with the interplay, the in-between between them, rather than treating one way of communicating as the right or preferred or default way and trying to bring the other person up to speed. It involves mutual curiosity and respect. So instead of assuming miscommunication is due to a flaw in one person, this approach encourages partners to be curious about each other's communication styles. For example, an autistic partner may prefer direct and literal language, while the neurotypical partner might rely more on subtext or emotional cues. Both are valid, and listening to each other's language deepens misunderstandings. In fact, finding shared language was one of the funnest things, I suppose, that I did as a relationship counsellor, finding something that both partners could relate to, and then it becomes their own sort of private kind of shortcut language, which is really, really kind of cute. Shared meaning making. So rather than aiming for perfect understanding all the time, the goal becomes co-creating shared meaning. Partners can learn to ask clarifying questions, and we can support them to do that. Check assumptions, which is really, really important, and build a shared vocabulary that works for both. It involves a lot of regulation and repair, seeing communication breakdowns as a normal part of connection, not a failure. So when misunderstandings happen, the focus is on repairing the rupture with compassion rather than assigning blame. And this includes acknowledging differences in sensory needs, processing time, and emotional expression. Processing time was a big one for us, recognizing that we each had different processing speeds, and what I say, slowing down to speed up. By slowing down to give us both time to be, in the same space at the same time, we actually sped up the process. So yeah, that's what worked for us. Balancing needs, holding space for both partners' needs to be seen and supported, which might mean adjusting how and when conversation happens. For example, giving more time for processing, using written communication, or agreeing on cues for pausing a conversation. And I would say that it was probably using written communication that really started turning things around for my husband and I. My husband and I is a beautiful, beautiful letter writer. And that's one of the things that helped me to fall back in love with him all over again. So in a relational framework, partners see communication challenges as opportunities for growth, for intimacy, and for mutual evolution. They work together as a team to navigate differences rather than seeing each other as an obstacle, and they prioritize connection over correction. So let's talk now about a relational approach to executive functioning. This is something that used to frustrate me before I had a better understanding of how frustrating it was for my partner. How partners navigate challenges like planning, organizing, initiating tasks, emotional regulation or follow through, not as individual deficits to be fixed, which is probably how I used to see things, but as shared challenges to understand and manage together. And so rather than focusing on what one partner can or can't do, a relational perspective asks how can we support one another in a way that respects our differences and strengthens our connection. And so some ways that it might look like in practice are reframing executive functioning as a relational issue. Executive functioning challenges can be easily misinterpreted as laziness, avoidance, or a lack of care. But in a relational approach, partners learn to see these behaviors in context of the whole, recognizing this as a neurological difference, not as a character flaw. This shift in mindset, which I had to have, really softens frustration and invites compassion for the partner, which is a much nicer place for both partners to be. Shared responsibility, not scorekeeping. So instead of keeping mental tallies on who's doing more, especially when there's a new baby in the mix and there's more to be done, a relational approach asks, what do we each need right now in order to show up well in this shared life of ours? And this could involve creating flexible routines that work for both partners, agreeing on who initiates certain tasks and why, or using external supports like reminders, planners, or visual schedules, or outsourcing like Sarah suggested, not as crutches, but as co-created tools. The focus here is on interdependence and not independence. Naming and negotiating capacity, I think, is a really important part of this. So partners in neurodiverse relationships might have different energy thresholds, different sensory needs, different ways of processing stresses. Our relational approach encourages open, non-defensive conversations, which can be hard, especially when you're sleep deprived and tired, about each person's capacity on any given day or any given morning or any given afternoon without judgment. So instead of expecting consistency from each other at all times, the goal is more flexibility and fluidity, adjusting roles and responsibilities in ways that feel probably fair rather than equal. So not aiming for equality, but just aiming for what's fair for us today, and tomorrow could be different. And then repairing the emotional toll. Executive functioning differences can create patterns of resentment or emotional disconnection, especially if one partner feels overburdened or the other feels misunderstood. It encourages repair conversations that prioritize emotional safety, validating each other's experience, and reconnecting with shared values. Like, we both care about creating a calm home, even if we get there in different ways. So let's talk now about a relational approach to intersecting physical health concerns. In one or both partners, if one or both partners are autistic or ADHD, they're likely to have other health concerns or more complications with the whole gamut of parenthood, trying to conceive, pregnancy, labor, birth, delivery, recovery, and breastfeeding. And this can put extra strain on one partner as the carer, or on both partners as carers as well as new parents. Birthing women often have different experiences of pain, and autistic women in particular might struggle to express their pain during labor. A partner who knows this of their partner, who knows their partner well, could advocate for her, and ideally they're held in this by professionals. The couple's likely to have a much better experience of togetherness and success if the partner understands how pain is expressed by their autistic or non-identified autistic partner. And I've worked with couples who've had what anyone else would have considered a traumatic birth, but they've described it as a wonderful experience because they went through it together and supported. And so I'm sure with the birth trauma, you know, as we know, it's the response to the trauma or how the trauma is managed that can be more or less traumatic as the birth itself. Conversely, you might have a neurotypical client whose partner is autistic or ADHD or ADHD. the impending stresses of pregnancy, birth, and new parent might show up for them as physical health complaints. And so you might have a neurotypical client who's having, or a neurodiverse client that's having to deal with that at the same time that they're dealing with their own pregnancy, birth, and postnatal experiences. I thought a little bit about this more, and physical pain is one thing and really important to address, as other speakers have done, but there's also emotional pain. And that was probably the hardest thing for my partner and I when we became new parents. You know, there's a saying in neurodiverse circles that two is more lonely than one in a neurodivergent relationship or a neurodiverse relationship. But when partners become parents, it can be a case of three is more lonely than one. And that can be incredibly, incredibly painful for both partners, feeling alone in that. But by working in relationship-based ways, we can absolutely minimize this. So a relational approach to sensory experiences and overload. This invites partners to understand and respond to each other's sensory worlds with empathy, flexibility, and the co-regulation that Sarah spoke about, rather than judgment or avoidance. Shifts the focus from what's wrong with you to how can we honor your experience and still stay connected through it. So seeing sensory experiences in a shared context, not as a personal problem. Where one partner is experiencing things more intensely, sound, light, touch, taste, or whatever, knowing that sensory overload's not a sign of weakness or overreaction or a rejection, not wanting to be here. It's a nervous system response. And so a relational approach helps couples to take shared responsibility for finding comfort, for finding ease, for finding pause in all of that. It becomes something that you navigate together, not something that one partner has to get over. It could mean mapping sensory needs, you know, and asking questions like what helps each of us to feel regulated or safe or present, what overwhelms each of us, and how can we notice early warning signs, because neurotypical partners can often get overwhelmed too, especially with new parenthood. All you know, feeling touched out, feeling sick of body fluids, and you know, all the rest of it. How can each of us express sensory distress without any shame or shutdown? So instead of viewing sensory differences as limitations, this can be an opportunity for them to become valuable insights into how to care for one another more deeply and co-create co-regulating environments so that both partners feel supported. The key here, I guess, is collaboration. How do we shape our home, our routines, or even our social lives to reflect both of our nervous systems? Like when I go out with my husband for dinner now, we choose quiet restaurants. We choose restaurants where we know that we can have a conversation without too much external noise going on. We don't go out and see bands anymore. Okay. So, you know, you could support your clients to ask for what they need in those moments. You know, it might be, I'm feeling saturated. Can we pause? Or my body feels really tight right now. I need 5 minutes to adjust. Or simply, you know, couples could have a hand signal or a word that says, you know, I need time out right now, but I still care. There's lots and lots of ways that we can work in relationship-based ways with all of these typical neurodiverse kind of issues, I suppose. Okay, so now let's talk about a relational approach to overwhelm, meltdowns, and autistic burnout. This approach invites both partners to view distress through a lens of connection and compassion rather than pathology or personal failure. Asking questions like, how can we move through these moments together, similar to the previous ones? How can we manage this safely, gently, and with our relationship intact? So looking at relational events happening within the dynamic between us, and that requires shared understanding, co-regulation, and repair, similar to the previous, you know, the sensory overload. Overwhelm and burnout are an accumulation of sensory, social, and emotional strain over time, often from masking navigating neurotypical norms, or living without accommodations. And I don't think I realized the depth that my partner struggled with some of this stuff. And it was so eye-opening for me to then know that, and then to make space for all of that in our relationship going forward. So asking questions like, from a relational approach, like what contributes to overwhelm or shut down for them, but also for me. You know, I can have my neurotypical overwhelm meltdowns and want to shut the world out too. Like, it's not, you know, but both partners, all people, we all experience this, right? It's just recognizing the additional challenges, you know, that might be for our partner or for our client in this space. What does meltdown or burnout look like for each of us, and what protective patterns do we fall into, and how do they affect the relationship over time? So framing these as nervous system overloads, not personal shortcomings, and co-creating a supportive response to meltdowns. And that could be avoiding questions or problem solving in the moment, which is not helpful necessarily. Offering presence without pressure. I'm here when you're ready. And recognizing that space is often the most loving response that we can give a partner or a client. And then after the meltdown, lots and lots of repair, gently debriefing, and what helped, what didn't, can really be helpful. And that's something that we do regularly now. So recognizing also that autistic burnout is long-term. It's a deep body level exhaustion that comes from chronic stress. And so spotting early warning signs for that, adjusting expectations for what's possible, reducing demands when that happens, and building recovery into daily life as a prevention, not just waiting until the collapse happens. Making space for both partners' needs. Naming and validating the impact on both partners, creating agreements about how to communicate this, and just wayfinding, I suppose, through the hard days, saying, I don't know what to do, but I want to stay close, or I want to be here for you. Naming a hard moment in a pattern could be helpful. We've been here before. What helped us to get through this last time? And trusting that connection can be rebuilt even after rupture. Okay. So finally, let's talk about building a relational compass. And I'm going to zoom through this, Bron. I know we're getting close to time. So a relational compass will really depend on where you are working at with a client, what level you work at with a client. Is it the events level? Is it with the process level? What's happened over time? Is it the systems level? Is it the mental models that you're working with? Or if you're working as a psychologist or a counselor or somebody that's working long time with clients, even going deeper and questioning, is the model that I'm working with, you know, built for neurodiverse relationships? Is it trauma informed, and is it relationship based, which I think is probably the gold standard 1, 2, 3 for this kind of work. So if we were to ask wayfinding questions, they might be things along the lines of, where have we been? You know, where have we been? What's happened that's brought us to this point? It could be, where are we now? Like, you know, where are we today? How are we right now? Are we feeling close? Are we feeling distant? I used to say to couples, do you feel 10 steps closer or 10 steps further apart when your partner says this to you? There's lots of little hints and hints and, you know what I mean, that you can use for that. What do you see? I love the duck bunny example in the podcast that you've got, I know, in your notes. I really thoroughly recommend you go back to listen to that if you haven't had time. What do you see? Do you see a duck or do you see a bunny? And the answer is, it's both. And then, where do we want to be? And that's often things like shared values and aligning values, you know, of openness, honesty, trust, safety, reliability, and also aligning goals, a happy and healthy neurodiverse family. You know, that's the goal for us now that we can talk about it openly because we've got the diagnosis. And where can we meet? And I'm reminded by this of Kent Hoffman, where can meet me in Chicago. A healthy, loving, supportive relationship isn't about right or wrong. It's not even about agreement. It's about connecting. And if we said to somebody, where do we meet? Meet me in Sydney, let's say. We're not going to be able to meet in Sydney. If we said, meet me in the Rocks in Sydney, we're not going to be able to meet in the Rocks in Sydney. If we said, meet me on George Street in the Rocks in Sydney, we might pass each other, we might not. But if we said, meet me at the Rocks Cafe at 66 George Street at 10 a.m., connection can happen straight away. And it's almost like the more we know about the person that we're trying to connect with, the easier it is to connect with them. And that's what's happened with my husband and I. This is what we can do as care providers: widen our lens, be curious, make space for both partners, and adopt frameworks that support the whole family. And yeah, my husband and I are meeting at 66 George Street in the Rocks in Sydney these days. We were opposites, but sometimes opposites can attract, and we're finally figuring that out in lots of different ways. So thank you very much for your time, for your work with parents. Come find me if you want to know more at Becoming Us Family, or Ellie@ellietaylor.com.
Ellie, take a well-deserved deep breath, and everyone, we can take a deep cleansing breath together. That was wonderful and inspiring. I love your honesty in this space, Ellie. Love that there's so much you can offer with working with neurodivergent couples. The couple relationship is its own entity that requires attention and TLC during the perinatal period, right? So thank you for reminding us of that. And I love your consideration of those 5 common vulnerabilities through a relational lens. It's so helpful. There's so much gold in there. I just want to read you a comment that has come through in the chat, and I invite everyone who's live now to pop in your comments or questions. Okay. Absolutely loving the compassionate way Ellie is reflecting on the neurodiverse couple experience, reflecting on that past position of feeling blame or judgment towards the neurodivergent partner due to viewing through the neuronormative lens. Yeah. And I love your quote that you repeated at least 3 times: difference is not deficit. Yeah. So it's a good one to take away as well. Ellie, thank you. Hold tight. Where we're going to go now, for those of you who are live, we are going to launch the poll. There's been a lot of content here in this session, both from Ellie and from Sarah. We would love to get your feedback. If you've been with us in a live so far in this conference, you're familiar with what's going to happen. What you will see is the poll coming up on your screen. And there are 4 questions, 2 related to Ellie's presentation, 2 related to Sarah's presentation. And there are 4 options to choose from. We would love to get your feedback. This part is anonymous. We'll give you a little bit of time there. And just going ahead with that poll. And I'm guessing that's coming through, Nikki, and that we're getting some results there. Yep, that's looking good. And maybe just another moment. Thank you for letting us know what you think and where you're at with this content. And I'm guessing that might be a reasonable time to wrap up and close that poll, Nikki, if you can. And you can share the results. People live will be able to see that. Great. All right, thank you everyone for participating in that. And by way of some final reflections, here comes a reflective prompt for you to help consolidate your learning. And we'll pop that in the chat box as a prompt. If you would, please share one thing you are taking from today, either presentation. What is one thing that you think, I'm grabbing hold of that with both hands? and I'm not letting it go. Something from Sarah's presentation or something from Ellie's presentation. What is sticking with you? What is sticking with you? Now, I'm guessing some comments are coming through. Thank you for taking the time to type those in. Oh, that is a really important. Oh, absolutely loving the compassionate way, Ellie. Oh, I read that. Yes, so many things to consider for dads that aren't commonly talked about in general society.
Mhm.
Always being the curious wanderer for all members of the family. Love that. Difference is not deficit. The essential inclusion of partners in the perinatal space. Let's champion that. Holding space for the whole family, looking beyond the presenting issue. Great. Yeah. Some great things coming through there. Please feel free to keep those comments coming. We love that. That's very, it's helpful for each of you, I think, to commit to something, but it's also helpful for us and the presenters, that's for sure. Everyone, thank you for your attendance today for another amazing session. We are on again live tomorrow morning, Aussie time. If you're joining us live, we would love to see you. For now, as you log out of this live stream, you can make your way into the meeting hub, and Ellie and Sarah will be there to answer your questions that have remained unanswered, and you can connect with others if you wish to. Other than that, it's bye from me just now, and we'll catch you tomorrow in the next session. Bye-bye. Thank you.